Why don't we start?
There's still a few people coming in, so
Okay.
we'll just wait a little bit longer. And as soon as I see the people are no longer entering, we'll begin. And if people enter late, I'll just let them in.
Okay, Belle, or a little longer? Okay.
No, I think we can begin.
All right. Good evening. My name is Mark Cantor. As president of the Jewish Heritage Center of Western Canada, I would like to welcome all of you to this evening's program. I note that the program is being recorded and all questions must be sent via the Q&A. The mission of the Jewish Heritage Center of Western Canada is to document, preserve, and share information on the culture and historical formation of Jewish communities in Western Canada. The center also serves as an advocate for anti-racism and education on the Holocaust and anti-Semitism. Our vision is to forge a pathway to the future by preserving and sharing compelling stories and educating present and future generations. This vision was aptly described recently by one of our benefactors in the following manner, and I quote, "You can't look to the future unless you preserve the past." I encourage you to visit our website to learn more about our organization and our upcoming events at JHCWC. That's the acronym for Jewish Heritage Center of Western Canada. Again, jhcwc.org. O-R-G. I'd like to acknowledge that the Jewish Heritage Center of Western Canada is located on ancestral lands on Treaty 1 territory. The Red River Valley is also the birthplace of the Métis. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. May we live with respect on this land and live in peace and friendship with its peoples. I would now like to introduce Dr. Ted Lyons. Ted Lyons did his under- and postgraduate medical education at the University of Manitoba, graduating in 1973 with Canadian and American Fellowship Certification in Diagnostic Radiology. He did a year of research in ultrasound in 1971. He served for many years as professor and chairman of the Department of Radiology at the University of Manitoba, and since stepping down, he has continued his clinical and research work at the Health Sciences Center in diagnostic ultrasound. Ted is also the past president of the Manitoba Association of Radiologists, the Jewish Federation of Winnipeg, the Simkin Center, Congregation Sher Zedek Synagogue, and the Canadian Association of Radiologists. Among his many distinguished awards are the Queen Elizabeth Diamond Jubilee Medal, honorary membership in the CMA, the Saul Caney Distinguished Jewish Community Service Medal in 2014, the Society of Radiologists and Ultrasound Distinguished Service Award in 2015, and the University of Manitoba Distinguished Alumni Award for Lifetime Achievement in 2016. In July 2007, Ted was appointed as an officer of the Order of Canada, one of the highest honors that can be given to a Canadian by the Governor General of Canada. It recognizes a lifetime of achievement and merit of a high degree, especially in service to Canada or to humanity at large. Last but not least, Ted is a member of the Board of Directors of the Jewish Heritage Center of Western Canada. I now pass it over to Ted.
Dr. Marissa Becker, our guest from far away in New Delhi, India, is an associate professor in the Institute of Global Public Health at the University of Manitoba, departments of Community Health Sciences, Medical Microbiology, and Infectious Diseases. She's currently working as an infectious disease and HIV physician and researcher with the University of Manitoba. She uses a program science approach for her research in Manitoba, in India, Kenya, and the Ukraine. And her program of research focuses on understanding HIV and other infectious disease risk, vulnerability, and outcomes amongst marginalized populations, with a specific focus on adolescent girls, young women, and female sex workers. She has been awarded a Canadian Institutes for Health Research New Investigator Award for her research. Dr. Becker is currently based in New Delhi, India, where she is the Director, Technical Collaborations for the Institute of Global Public Health. Welcome, Marissa. Our next guest is Dr. Nathan Stahl, star of radio, TV, and the Jewish Post. He received his medical degree from Western University and completed his residency in internal medicine and fellowship training in geriatric medicine at the University of Toronto. He is currently a research fellow at Women's College Research Institute at Women's College Hospital and is completing a PhD in clinical epidemiology and healthcare research at the Institute of Health Policy, Management and Evaluation at the University of Toronto. His doctoral research uses large administrative databases to study the population health impact of caregiving for dementia. His other research interests include drug safety for older adults, sex and gender-based determinants of aging, and healthcare utilization amongst persons with dementia. During the COVID-19 pandemic, he has been actively involved in research modeling long-term care home outbreaks and factors associated with the outbreaks occurring and spread of COVID-19 throughout homes. He is currently the Assistant Scientific Director of Ontario's COVID-19 Science Advisory Panel. His research is supported by University of Toronto Department of Medicine's Elliott Phillipson Clinical Scientist Training Program and the Vanier Canada Graduate Scholarship. He has been a staff geriatrician at Sinai Health Systems since 2017. His clinical work focuses on acute care geriatrics. Dr. Stahl attends on the inpatient geriatric medical consultation service and on internal medicine clinical teaching units at Mount Sinai Hospital. Welcome, Nathan. Well, now let's begin the program. And if we can start with Marissa to speak on, again, the topic is the pandemic and a Jewish perspective in the care and in the outcome of care. Marissa.
Thanks very much, Dr. Lyons, for the welcome, and thank you to Bell and the Jewish Heritage Center for inviting me. It's a real honor to be here. I'm just going to pull up my slides. Bell, I'm wondering if you could allow me to be co-host so that I can pull up my slides. Perfect. Thank you so much. Okay. Okay, I'm hopeful that you can see my slides.
We can.
Oh, perfect. Thank you. Okay, so this is a bit of a different talk for me than the traditional scientific talks that I normally present. So I thought I might start by backing up and telling you a little bit more about me, who I am, my work, and then about my COVID experiences. And I'll try to tie this back to how I see the intersection of Judaism and Jewish values. And I'm starting this way because who I am influences what I do, how I act, and what I want to see in our world. So I'm a mother of twins. boys, Noam and Ephraim, 10 years old, who are filled with energy and curiosity. I'm a wife to Mark, a sister to Pam and Lev, an auntie, and a daughter to Alan and Lynn, who I think are tuned in tonight. And I grew up in a household of caregivers. As Dr. Lyons introduced at the start, by way of work, I'm an infectious disease physician and public health researcher with the Institute for Global Public Health at the University of Manitoba, and I'm currently living in Delhi, India with my family. My clinical work in Winnipeg is largely focused on providing care to people living with HIV. But I'm here in India to provide support to the university's work in global public health. We've had long-standing and large-scale programs wherein we provide technical support to state governments to help them optimize their public health programs and achieve their health goals, mainly in the areas of HIV and other infectious diseases and in maternal and child health. And my work here isn't clinical. It's focused on supporting public health programs and engaging in embedded and applied public health research. And this is the perspective from which I'll speak tonight. We are virtually together tonight because of the pandemic. To date, the pandemic has resulted in 240 million people diagnosed with COVID and almost 5 million deaths. And both of those figures are likely an underestimate. I've experienced the pandemic in two different worlds, here in India and in Winnipeg. Both places are vastly different in many ways, socioculturally, how healthcare services are designed and delivered, and the resulting impact of the epidemic. But there are also many commonalities, and I think this pandemic has certainly shown us how connected we are. We were living here in Delhi when in April and May of this year, we had the very devastating wave that made news around the world, with images of people desperately trying to find hospital beds and oxygen for themselves and for sick family members. I think it's something that will be with me for a very long time. Imagine Delhi, a city of over 20 million people, normally filled with the sounds of daily life, very loud and very vibrant. But during April and May, during the lockdown, it was absolutely still, quiet, with the exception of sirens. We would go out to sit on our terrace and listen, and all you could hear were birds and sirens, sirens and birds. It was so eerie, and you could immediately feel the impact of what was happening in the community around you. The situation here was really difficult, and the health system in many areas across the country was completely overwhelmed. The impact was immense. The healthcare facilities were full, and many were faced with a lack of sufficient equipment and supplies. Families really struggled. On top of trying to cope with loved ones that were sick, many incurred significant financial costs, catastrophic out-of-pocket expenses that'll affect those families for years to come. When the pandemic first hit India in early 2020, our teams were asked by the government of Uttar Pradesh, the biggest state in which we work, with a population of over 220 million people, to provide support to address the pandemic, which we did in a number of ways. Our team helped the government in implementing a multi-pronged strategy to address the pandemic using data for decision-making. We helped the government establish a very comprehensive COVID surveillance system. We provided training and support to frontline workers in the community around prevention measures and for community surveillance. We provided training and support to care providers and facilities, and we've supported the government in forecasting to plan for equipment and supplies, and in conducting COVID seroprevalence studies. At the same time, we knew we also needed to resume essential services for pregnant moms and children, which is the focus of our work in Uttar Pradesh, as soon as possible. Uttar Pradesh has some of the highest rates of maternal and neonatal mortality in India, and so resuming services was essential. And I've often been asked why the University of Manitoba is here, not only for the COVID pandemic, but for our broader public health work. Why me as an academic and as a physician? And I'm not sure that I have a simple answer, but I think it very much links to our responsibilities as care providers and as academics. And part of the university's mission, in fact, relates to service. And I'll read you the U of M's mission: to create, preserve, communicate, and apply knowledge, contributing to the cultural, social, and economic well-being of the people of Manitoba, Canada, and the world. And as academics, we need to keep making sure we're using science and good data to inform our response to the pandemic. It is so critical right now. We must learn from this pandemic in effort to prevent and better address future epidemics and to mitigate their very significant consequences from a public health perspective, as well as the social and financial consequences. So how does all of this relate to our task for this evening? We were asked to speak about the intersection of Jewish values and healthcare and the response to the pandemic. And I'll admit I had a hard time with this task because it challenged me with having to disentangle many things. So in preparing for this talk, I do what I always do. I researched. And it's interesting when you start to look. There's a tremendous range of what is presented as Jewish values. But I came across three that really resonated with me. And three which I will focus on this evening: Tikkun Olam, Gemilut Chasidim, and Kehillah. Tikkun Olam, repairing or improving the world. Gemilut Chasidim, acts of loving kindness, and Kehillah, community. And I think those have been driving values or philosophies for me for a very long time, before even entering into medicine. I'm proud to say that I received the Menschlichkeit Award from Joseph Walensky a few years running. And I don't believe, though, that those values are unique to Jewish people, because I've seen them exemplified in many cultures and communities around the world. But I do believe that they are very strong values expressed or embodied through Jewish traditions and culture. And they certainly were in my home growing up. And it's the way that my husband and I are trying to raise our children. From a very young age, we've carted them around the world, and through experiencing different places and different cultures, I believe that they are learning that the world's a big place, made up of people of different shapes, sizes, colors, and religions. And yet at our core, we share so much in common. And through this, we need to look after one another, through Tikkun Olam, Gemilut Chasidim, and Kehillah. And we're not done yet. We are far from the end of this pandemic. This pandemic and others before this magnify our global inequities. Around the world, the poorest of the poor tend to have the worst health outcomes. Even within the highest income countries, poor health outcomes are disproportionately experienced by individuals in lower socioeconomic positions. So in the context of the COVID pandemic and the public health response, we need to understand how it has impacted the overall health and well-being of people, particularly those living in marginalized or vulnerable circumstances, so that we can inform our response. There was a really nice editorial quite early in the pandemic about redefining vulnerability. And we learned early about those individuals at higher risk of death, older adults, people with heart disease, etc. But in the context of the pandemic and the public health response, this article reminded us that we needed to rethink what we mean when we speak of vulnerability. For example, individuals unstably housed or living in poor housing conditions and crowded housing, those with lack of access to clean water. Imagine the challenges faced in terms of being able to follow prevention measures. And most recently, we are seeing these inequities play out in the vaccine response. This figures from a recent paper on achieving global equity for COVID vaccines. It shows the sharp disparity between high income and lower income countries by proportion of people with at least one dose of a COVID vaccine. And the authors from that same paper note some key steps that can be taken to address these inequities, and I've just listed a few of them here. They include the immediate distribution of unallocated or reserved doses of vaccines, ramping up production and distribution capacity for vaccines, technology transfer to enable more vaccine manufacturers to produce vaccine, a fully funded and internationally coordinated initiative to facilitate tech transfer, building of vaccine manufacturing, scientific and regulatory capacity. And they note that these initiatives require genuine commitment to working collectively in the common interest to promote global equity to COVID vaccines and pandemic responses and preparedness. And we're getting there in India, slowly, but it is moving. It's been with mammoth effort and commitment. India just today celebrated the delivery of 1 billion vaccinations. And often in global health, we're faced with what feels like impossibilities. Immunizing over 1 billion people here in India, for example. I think we all feel some of that now in the context of COVID. So I'm going to finish with a quote from a famous Jewish philosopher, Shel Silverstein. And I must have read The Giving Tree growing up countless times, and so have my kids, along with his other books. And if you haven't, you must. It's something that he wrote in one of his poems, which speaks to possibilities. And I think in the context of our talk this evening and the discussion, it's something that we have to keep in our focus. So he wrote, "How much good inside a day depends how good you live them. How much love inside a friend, it depends how much you give them." I'm going to stop. Thank you.
Beautiful, Marissa. Thank you very much. Excellent, excellent talk. Very thought-provoking. Nathan?
Thank
Can
you.
we ask you to share your thoughts?
Absolutely. So thank you very much also to Bell and to the Jewish Heritage Center for inviting me to speak. I am a Winnipegger by birth. Left when I was 2 and have many roots to the city. Both sides of my family are from there. And so it's always a pleasure to be back, even if it's virtually this time. I will also say that Dr. Becker and I have actually never met, but I also have twins. I have twin girls who are 4 years old. And I'm also a Shel Silverstein fan. And in fact, I just read The Giving Tree to my kids yesterday. So, and the final piece I'll just share with Dr. Becker is that I did spend a summer in the south of India doing tuberculosis research, which was the first actually scientific paper I've ever published. So I'm going to speak. I'm a geriatrician in Toronto at Mount Sinai Hospital, and the pandemic really put my patient population and who I have dedicated my career to, really in the line of fire in a way that I don't think I ever anticipated in my career. And so I'm going to talk maybe less eloquently than Dr. Becker about 3 sort of Jewish themes that I will tie into my pandemic experience, which in Toronto has admittedly been very different. So the first theme that I want to just frame the talk with is a quote from Rabbi Nachman of Breslov, which is, "Gauge a country's prosperity by its treatment of the aged." And Canada, unlike India, in many ways is a rich country. But I think in terms of prosperity, by judging it by our treatment of our aged, we performed pretty poorly over this pandemic. So to date, if you look at just raw statistics of COVID-19 cases in the country, about 16.4% of all cases are in people over the age of 60. But 60% of hospitalizations, 58% of ICU admissions, and a staggering over 90% of all deaths have been among people who are over the age of 60. And if you look at that data, so if you look at all the deaths in Canada thus far, we've had tragic 28,191 deaths, according to the latest data from Health Canada. 15,535 of those, or 55%, have actually occurred within what you call personal care homes in Manitoba. We call long-term care homes, called nursing homes in other parts of the world, and retirement homes or assisted living facilities. And why is that related to our treatment of the elderly or our lack of prosperity? I think this will continue to be a national shame in Canada, what happened during the COVID-19 pandemic, particularly for those who live in these congregate care settings like personal care homes and assisted living or retirement homes. There was a few things I think we failed and why we are poor in this regard. I think one of them is this concept of fatalism, versus fatal errors. And I think a lot of decision makers thought about the death of elderly as a fatalistic thing. So even the health minister, the former health minister, Cameron Friesen, said that the deaths of people in care homes in Manitoba were unavoidable. And that was that fatalistic approach, as opposed to the fatal errors that were made. Not all these deaths were certainly preventable, but decisions were made in terms of how we prioritize the elderly. And this is not unique to Manitoba. This happened in Ontario. And in Canada, in the first wave of COVID-19, 80% of all of our deaths happened in long-term care homes. And that was actually the highest proportion of a country's deaths occurring in a long-term care home out of all the OECD countries. And so decisions were made about trade-offs between the economy and protecting the elderly. There was a false sense that we could shield this population, shield the vulnerable, and let the virus run rampant among everyone else and somehow protect them. In my own province of Ontario, they talked about building an iron ring around long-term care homes, which was a myth, really, that could exist. And then there was what happened at the beginning of the pandemic about prioritizing critical care settings over the long-term care settings. And we know that there was planning and resources put towards those settings, which we had the real fear of overwhelming at the expense at times of long-term care homes. And so that had the result, in spring of 2020, our hospital was paired with a long-term care home that had a catastrophic outbreak. And I saw things that I never expected to see in Canada. The home that we were involved with, 25% of the residents died. So about 30 residents died in a very short amount of time. Before we arrived, they were using coat hangers to hang things like bags of saline to hydrate the patients. They didn't have oxygen tanks, which we needed to taxi from our hospital. And so we had a real neglect of older adults, and particularly those living within these congregate care settings. So that's that first sort of theme, that Jewish theme of gauging a country's prosperity by the treatment of its aged. And I argue that Canada was not prosperous. We were actually quite poor. The second theme, and I will admit that I am not a Torah scholar, but I did look up this week's Parsha, and this week's Parsha is Vayera. And there's some remarkable things in this, but it is the Parsha where Abraham is actually circumcised at the ripe age of 99, which I'm not sure whether any other circumcision has happened subsequently at that age in the history of humanity, but he was circumcised at the age of 99. And Hashem, as part of visiting, the Parsha is him visiting, or he actually sends, as part of Bikur Cholim, or tending to the ill, he sends 3 angels who are disguised as men. And he recognizes that for Abraham, what he needed in terms of the care he needed to receive was actually to be given the opportunity to care for others, to be empowered as a caregiver. And so the link I would draw between this week's Parsha and actually the COVID-19 pandemic was another big failure, particularly as it related to my patient population, which was the exclusion of caregivers and family caregivers. And so at the onset of the pandemic, way back in March 2020, the knee-jerk response for long-term care homes and retirement homes or personal care homes was to actually close the doors of these facilities to family members and to shut them out because there was a fear of bringing the virus in. And that probably most initially was a quite reasonable response. The issue was the exclusion of those individuals persisted for months. And we know that people within these settings have very limited life expectancies. And particularly in Ontario, when we were doing things early on, like calling in the army to care for some of the people in these homes, there were family members who were desperate to get into these homes to provide for their loved ones, to provide just basic things like hydration and food. And there was an article that really turned my head in the spring, where there were French physicians who talked about the confinement syndrome being worse than COVID-19 itself. And the confinement syndrome was a state that they started to describe amongst the residents of these homes. Because they were shut out from their loved ones and their caregivers, they became shells of themselves. And that word confinement syndrome is actually appropriated from literature used to describe prisoners who've been in solitary confinement, who have had prolonged periods of sensory deprivation and lack of contact with other individuals. And we saw this clinically, where people living in these places would go from walking to not walking, and I'd look after them in the hospital because they break their hip, or they had an accelerated decline of their cognition, or they would have increased use of medications like antidepressants and antipsychotics, or, you know, perhaps most heartbreakingly, when they did get let back in several months later, the resident no longer recognized their loved one. And this was a persistent theme. And it went on for a very long time. Beyond when I would argue we were opening up the rest of society, we continued to keep these settings closed and not give some autonomy to the residents and some empowerment of the caregiver to provide the, you know, basic, not basic always, sometimes it's intense, but some of the basic needs for these residents to meet their physical needs, their emotional needs, their psychological needs. And so that changed across the country in a staggered sort of way. But, you know, Manitoba, for example, developed these sort of all-season visitation structures where they took shipping containers and tried to make something that was outdoors. This was in the sort of pre-vaccination area. But that shutting out of caregivers and the lack of empowerment and recognition about how essential they were did harm to residents, but it also did harm to caregivers in terms of trauma, because many of them missed the deaths, or many of them missed a substantial proportion of their loved ones' lives, or they witnessed this accelerated and severe decline. And so linking it back to the Parsha, that concept of empowering the caregiver and recognizing their essential role within our health, our social, and our long-term care system is something that is such an important value. And the third thing I want to end with is this concept of mipnei seva takum, literally standing up for the learned and standing up for the elderly. And I think there's a number of ways which, you know, the pandemic has really highlighted the need to stand up for older adults. That's something that we tried to do in Ontario. That's something that colleagues tried to do across the country. But I would argue that we know this, that ageism is actually one of the most prominent forms of discrimination, but also one of the ones that most goes unchallenged and is most socially accepted. And so there's a real need coming out of this pandemic to give a voice to often the voiceless, and to recognize older adults and to advocate for them in a much stronger way. So, you know, I think back to the very onset of the pandemic. Another Winnipegger, my close colleague and friend, Samir Sinha, we wrote an editorial in the Globe and Mail, and we titled it Ageism, or COVID-19 is not the only thing that has gone viral, ageism has too. And we were extremely bothered, as I continue to be now, by the sentiment early on that only older adults were being impacted and we shouldn't change our way of life to protect them. That there was this risk, which still persists among people when it relates to things like vaccination, of an invincibility among young people. There were even public figures at the time, a lieutenant governor in Texas who said that he, who was elderly, and people of his demographic would be willing to be sacrificed so they didn't sacrifice the American economy. And so this was a persistent theme that we've seen repeatedly over the pandemic. And particularly as we continue to need to bring in public health restrictions and relax them, and bring them in and relax them, when we bring them in, there's this persistent theme that we shouldn't be doing things that impose on the rest of us to protect older adults. And that's been another common theme during the pandemic, is really standing up for older adults, that concept of mipnei seva takum, to stand up for them, to give them a voice. So, you know, when we had to argue to them that the best way to prevent COVID-19 outbreaks within long-term care homes was to actually control the spread in the community, that was in direct opposition with political decisions like wanting to keep the economy open. And so these were these fatal errors that were made, where there was this fatalistic approach, but there was also value judgments being made about how many older adults would die to allow us to have an economy that's open and a society that's opening. And we're seeing this tragically in places like Alberta, now in Saskatchewan, which, my own hospital is receiving patients from Saskatchewan, that decisions are made that haven't always stood up for those who were voiceless or more vulnerable or marginalized in this. Now it's a different demographic that's ending up in the ICUs in Saskatchewan, mostly the unvaccinated people, but there are, as we've seen, older adults who, Colin Powell's a prime example of somebody who is fully vaccinated, is an older adult, has cancer and is on treatment, and because of decisions, that don't necessarily relate to not only oneself but to others to get vaccinated, resulted in the death of an older adult like him. So those three concepts of Rabbi Nachman Breslov's concept of gauging a country's prosperity by its treatment of aged, and my argument that Canada is not prosperous or has not been prosperous during this pandemic, the concept or the Parsha Vayera of empowering the caregiver, and that third concept of Mipnei Seva Takum, of standing up for the learned and particularly the elderly, are three Jewish values that have been a recurring theme during the pandemic for me, but has also guided me in terms of the work we did and the advocacy efforts that we took. So with that, I'll hand it back to Dr. Lyons, and I look forward to the discussion.
Nathan, spectacular. Both you and Marissa really wrapped it up beautifully, bringing in the Jewish values. My question to you is this a pandemic or an endemic? Are we in it for the very, very long haul? And how are we going to, all the things that you've said, how we have tried desperately to respond to the pandemic, but at huge costs to the elderly, costs to the economy. Are we ever going to get out of this? Or is this just pandemic 1.0 to be followed by endemic 2.0?
I'll defer to the infectious disease doctor first, and then I can supplement with my inferior geriatric medicine thoughts.
Great, thanks, Nathan. Okay, so I will. I'll try to answer it, but I'll also acknowledge that I tend to be an eternal optimist, and so I think we will get through it. I think we've made a tremendous amount of progress. I think there are lots of questions about what is going to happen in terms of whether it will shift to an endemic virus in some places, or whether it'll be a recurring epidemic like we see with influenza or other viruses. So I think I don't have an answer for it as of yet. I think that with COVID, we have learned a lot at a remarkable speed in terms of how knowledge has been generated and what we've understood about the pandemic. So I think we still have a lot to learn. And I don't think that we can answer that question as of yet, but I think there has been a lot of progress that's been made. And if we think about, vaccine development, what's been happening on a treatment front, these are all things that are paths towards moving through this. What that looks like towards the other side, I think is still unknown. But I think that given all of the tremendous advances in terms of both prevention as well as now a little bit on the treatment side, I think there is a way forward and a way to move through this. And just with our general understanding of the epidemiology of the disease and transmission dynamics, I think that we'll be better able to continue to manage it. But I think, as Nathan has pointed out, there are still lots of places where we need to learn a lot more and do a lot more. And so that if we can make those continued commitments to doing that, will hopefully help move us forward even further and faster. Nathan.
Yeah, thanks. I mean, look, in the history of humanity, all pandemics have ended, right? And they've ended. But so I think we have to separate whether the pandemic will end and whether we will always live with SARS-CoV-2 or the virus that causes COVID-19. I think the pandemic will certainly end. I think what we've come to learn is that as the the SARS-CoV-2 virus has changed over the course of the pandemic, it's become a different opponent. And so countries that had tremendous success early on, like New Zealand or other, Atlantic Canada is another example that really strove for elimination. That's not going to be a possibility with this in terms of how we deal with SARS-CoV-2. It's going to come through people getting infected or people getting vaccinated. And we want to maximize the number of people who get vaccinated. And to Marissa's point, we have, in Canada, we have the great fortune of having almost one of every 5 people who are eligible, 4 out of every 5 people who are eligible for the vaccine to have the vaccine. And everyone in our country has had the opportunity to be vaccinated now for several months. But the pandemic will not end on a global scale until we vaccinate the world. And so, yes, the pandemic will end. The speed with which it ends will relate to some of the things that Marissa talked about in terms of global vaccine equity and how we support those countries that don't have the good fortune of Canada. It will end, but I don't think the virus will be eliminated.
Let me ask you about the effect of the Merck pill, the little red pill that is supposed to be the be all and end all, that if you do get COVID, this pill will really prevent you from the worst effects of it. Is this reality? Is this coming soon? Is this the saving grace? Nathan?
You want me to start on this one? This is another antiviral drug question. So, one of the, so the pill is called Molnupiravir. Sorry, Marissa can correct me. I think it's called Molnupiravir. And, one of the things that we have seen through the pandemic is we have seen science by press release, and we have seen hype by press release as well. So yes, there is certainly promise about the use of this drug, but there has been promise with many things that haven't lived up to its hype. So we need to have the data seen to its conclusion, and this go through the usual process that we would evaluate other drugs. That being said, the best way still, even with the best treatments and therapies to prevent COVID-19 is not to get it in the first place. And so, we still want to maximize vaccination and preventing people through public health measures from getting infected. Because even if we can reduce the really bad outcomes, there are many things that we are learning about this virus that are not things that you want to have happen to you. The phenomenon of long COVID is an example. And so, preventing infection prevents you from needing even amazing therapeutics, but it also prevents you from other complications which might not be prevented by this. And so my thinking has always been that you do not want to get COVID-19, even if it's a mild form of the illness. And so this may live up to its hype. There's only been a few drugs that, a few drugs have emerged that have drastically changed the way we treat COVID-19. And, steroids is one of them in terms of it being easily accessible and cheap. The other thing, as Marissa will speak to, it will be the cost of this medication and its availability in places outside of first world countries. So those are my, again, non-infectious disease doctor thoughts.
Thank you. Marissa?
I fully agree with everything that Nathan has just said. I think that as a society, we're always looking for those, those magic bullets, right? We want to find those shiny things that'll help us to move forward through this. And I think that it might offer a little bit of promise for treatment, but I 100% stand behind that approach to really wanting to prevent disease. I think we're always better if we can work towards preventing disease, not only in the context of COVID, but with many other illnesses as well. And I think that to Nathan's comment about the accessibility of this drug, it will be expensive and it won't be something that is available to most people around the world. And so the more that we can do to prevent acquisition of SARS-CoV-2 through immunizations, the better we're going to be in terms of moving forward. And we know that with take the latest variant of Delta, that Delta just overwhelms things. And so getting those immunizations in place early on is really important. So I think shifting us to a place where we enable and facilitate and support more of the world's population to be vaccinated, I think will move us forward. But I think, research and development into treatment is still a really important part of what's happening in the world in terms of the pandemic response, because people will get sick. And so if there is something that can be available and help mitigate disease or severe disease for those, it is an important aspect. But I think if we step back and think about what do we need to do as a global society to move forward, I think the more we can put on prevention, the better that will be.
So as parents of young children, with the vaccine coming for children 5 to 12, is that something everybody should jump into?
I can start with a quick answer. I'm very supportive of it. I'm waiting. I'm not sure, Nathan, how old yours are, but we're waiting for that so that our kids will be eligible. And I think that all of these decisions obviously need to be taken in terms of the context of parents' situation and all, but the science has been extremely promising for vaccines. And I think that we've learned as more and more people are being immunized, kids 12 and up, about the safety of these vaccines. And we're hopeful for the extension to less than 12. So I'm a proponent.
So firstly, never trust a geriatrician's opinion on pediatric answers. But secondly, my kids are 4, so I will not have the opportunity to do so. I will highlight that, Angus Reid polling just came out yesterday that just 51% of Canadian parents of those 5 to 11 years old are actually would get the vaccine for their kids as soon as possible. So, Canada announced today, Minister Anand announced that they've secured enough of the Pfizer vaccine as soon as they have approval to have 1 dose for every Canadian child who the eligibility will be 5 to 11. If my kids were 5, I would certainly be rushing them to go get the vaccine. But I think all this speaks to a larger issue that there is going to be understandable concern from parents that needs to be met with compassion and information and counseling and guidance. And that's going to have to be part of the plan, right? I think one of the things that, here in Ontario, I would say we didn't do as well early on in terms of our vaccine rollout is we assumed that with supply would come demand. And there was a certain point when the supply outstripped the demand. And we're sort of in that last mile phase for months now of trying to convince that last 20%. That's probably going to be a lot larger than 20% when you're talking about this population. And so, that initial polling of 51% is much lower than the polling for adults was at this time before the adult vaccine rollout. And I think that's going to be an important thing to keep in mind in the coming weeks and months.
Marissa, you mentioned that today is a red letter day in India, having vaccinated 1 billion people. There's 1.1 billion people in India? Does that mean that everybody has had at least 1 dose of the vaccine?
So not yet. So they're celebrating 1 billion
Doses.
Doses, exactly. So a proportion of those will have been individuals that have had 2 doses, because that's a series that they're following here. So it's not quite yet it doesn't represent the numbers of people that have been immunized, but it is moving. And India has a long history of vaccines and vaccination programs that have been quite sort of decentralized in how they've rolled things out. So they were prepared, I think, to do this once they got sufficient supply to be able to take it to the village level. And they've done that. It was a little bit slow to start. And unfortunately, when the last wave in April and May hit so tremendously, it was at a time when the vaccine program hadn't yet really taken force. And so I think Delta hit prior to having a sufficient proportion of the population immunized. But since that time, I think they've really ramped up vaccination and have rolled it out. So yeah, it's been yesterday in India. They celebrated 1 billion doses, which is, it's a remarkable achievement.
Belle, there are some questions from the audience.
Indeed. So first of all, I'd like to encourage any of you in the viewing audience who have questions, if you haven't already submitted them, please type them into the Q&A. And I would like to start off with a question for Marissa in this case. In Canada, one of the really troublesome outcomes of this pandemic, of course, has been and these are two interconnected issues. On the one hand, the very loud anti-vaxxer movement and everything involved in that. And the other thing is the conspiracy theories against various groups, Jews being one of them, blamed for creating the virus, for making money on the vaccine, et cetera, and of course, Asians as well. So my question is, in India, do you see anything similar? Is there a reluctance at all by any groups to get the vaccines? Are they speaking out about this? And is there any blame laid on other groups, whether within India or outside of India?
Thanks, Belle. It's an important question, and I think in India there hasn't been. I'm going to speak from a general perspective. There's always going to be examples of those same types of things that have happened here, but there has not been to the same degree, I would say, the hesitancy with vaccinations that has been seen in other countries. Here, it was a matter of access, I think, and so the governments have had to solve for the problem of access and ensuring that all people would be able to take up the vaccine if they chose. So there was some hesitancy in the general population at the start because I think of an uncertainty around what the vaccine was, and I think everybody, that's a natural feeling. And so, with I think a fair bit of advocacy and a lot of education, and again, it's an area where I think India has done well historically in the past, is ensuring that education around an issue, in this case, COVID vaccinations, was done at a level that was also accessible for all. So, really novel and innovative campaigns at the village level to help people understand what the vaccine was about, to address people's concerns. But I think Nathan made a really important point earlier when he was talking about parents of children and some of the hesitation that they might have, how that often just takes time, a discussion, compassion to be able to work through that. And I think India did that to a degree as well initially, so that helped to overcome some of the hesitancy. And then it really became more of an issue of access to get people immunized. There are always going to be pockets of people that are hesitant to take up the vaccine. But I don't know that the same types of conspiracy theories came out here as we're seeing in other places. I will say it's not all roses. There's a bigger political context right now in terms of what's happening in the country. And so there is some marginalization of some populations within the country here on religious grounds. And so I think that initially there was some miscommunication, misunderstanding about sort of the role of some of these populations in terms of what was happening, both in terms of transmission and onwards. But I think there was enough pushback to be able to overcome some of that, so that it helped to probably mitigate what could have become a bigger issue.
Thank you. That's fascinating. We do have a few questions, and from Dan Stone, we actually have two questions. So Dan's first question is again for you, Marissa. He would like you to explain the graph at the end of your slideshow and say what CR stands for.
Sure, sorry. So that was a snapshot from one of the newspapers here. So CR is an abbreviation for crore, and crore refers to 10 million. So 1 crore would be 10 million. So that's what that reference was for. And the graph was about the progress in vaccine coverage over time. So it, as we just talked about, referred to the numbers of people and also the proportion of people that had received a vaccine.
Thank you. And Dan has another question for both of you. He asks if you have any insight into how healthcare workers can be anti-vaxxers. Is there any possibility that the anti-vaxxers are those who do jobs that do not require scientific training?
I could start with that. You know, one of the things that I think we have also not done so well, particularly in Ontario, in terms of our vaccination efforts, is we've somewhat homogenized the unvaccinated population. And so there is a group of individuals who are the sort of staunch anti-vaxxer conspiracy theorist types. Those people are probably not movable, or not probably, they're not movable. They're not going to be vaccinated. They represent, you know, whatever, where, depending where you are in the country, probably more sadly in Manitoba than in some other place, in some of the more eastern provinces, but and particularly in southern Manitoba, where I know that the rates are, you know, in the 40s. But there's also a group of individuals that, believe it or not, still haven't had the access that they need. And access can mean many different things. So homebound older adults, there are still people who haven't been served with people coming to their homes to provide the vaccination to them because they can't leave the home. And there are other people who have different accessibility challenges that just haven't been able to get the vaccine, whether it's for physical reasons, whether it's for psychiatric reasons, whether it's for social reasons. There are still all those people, they're not all those, but there is a substantial proportion of people that we haven't met that way. And then there's another group of individuals who I would classify as having, you know, within their frame of reference and their cultural and social reference, you know, reasonable fears and distrust of government. So, you know, if you look at, and some of the healthcare workers actually fall into this range. So, you know, we call them personal support workers in different places across the country. They're referred to different things. In Quebec, orderlies. A lot of these populations a lot of these individuals come from populations where they come from countries that they've had huge distrust of government, you know, so 40% of personal support workers in Ontario are actually visible minorities and racialized. And so many of these populations, you know, they may have, particularly if they're Afro-Canadians, they're fearful of things like the Tuskegee experiment and a history of government experimentation on that population. If they're Eastern European, there's that fear of government. And so there are, you know, things that need to be met, that sort of that sort of time and effort and outreach in a way that's not just the doctor, but through community leaders and outreach work for that last mile to convince those people. So I would just, you know, I think we need a caution against homogenizing the population. For healthcare workers, accessibility probably has not been the issue. There's going to be some of them who are those, you know, quote unquote anti-vaxxers, but there's also some of them that we really need to meet with compassion. We need to meet with outreach, and we need to meet by trying to undo sort of that generational sort of trauma that has been passed down because of prior harms and that have been inflicted upon their communities.
Did you want to add anything, Marissa?
No, that was perfectly said.
Oh, thank you. There's also Michelle Doctoroff is mentioning to you and to viewers that the Gabriel project in Mumbai, which was begun by an Israeli man and supported by the Joint Distribution Committee, are either of you aware of this, and do you have any comments in that regard?
I wasn't aware of it, but I did see that entered into the chat, and it's definitely something that I'm going to have a look at to check out. So thank you for bringing that to my attention, Michelle.
And Bernie Bellin says that he is always a little bit skeptical when he hears that a guiding precept of Jewish ethics is tikkun olam. Israel was determined to get as many of its citizens vaccinated quickly. If Israel had been adhering to tikkun olam, would it not have wanted to share vaccines with other countries that couldn't afford them? He's not suggesting that what Israel did was wrong, but he just doesn't think that tikkun olam came into play in its decision-making. Do either of you have any observations?
It's a big question. I can try to start. I think that there have been a number of really interesting papers that have come out talking about this issue of global equity around vaccines. And I think it's not a simple answer. It's a very complicated question, because understandably nations have a responsibility to look after their own citizens. And so decisions get made in that regard in order to be able to best support the health and well-being of their own citizens. So I think, though, the reason that I raised this issue of vaccine equity tonight is because I think it is something that we need to think about. And there was a mechanism set up early on in the pandemic to try to support the global distribution of vaccines. It ran into a number, it's called COVAX. It ran into a number of challenges, logistical challenges, administrative challenges, political challenges, I think. And so it hasn't been realized, I think, to the full potential that everybody really had hoped. I think the reason that I shared some of the recommendations from that paper that in my talk is that I think those are actually really solid approaches to trying to address this issue of inequity in immunizations globally. And so there are now a number of unreserved or unallocated vaccines that could be redistributed to support the rollout in other areas that have not had access to vaccines, particularly in Africa right now, I think is where the greatest shortage is. And so I think that there are ways in which we all and governments can make decisions about how to best protect the health and well-being of their citizens, which is a responsibility, but also making commitments to supporting this globally. Because I think, as Nathan commented earlier, we're not going to get through this until everybody is immunized around the world.
I fully agree with what Marissa said. I think we can use the specific example of third dose boosters as a real question that Canada right now is actively struggling with. There are the scientific reasons, but how do you balance, again, a country's responsibility to protect its own population with the need to protect the global population, recognizing that's the ultimate end to the pandemic. So I don't actually see it as perpendicular to Israel's sort of amazing vaccine rollout as perpendicular to tikkun olam, but I think, like many things in this pandemic, two things could be true. You can both prioritize your population while also prioritizing the global population. Israel, with the booster doses, was actually a different situation than Canada. They were having a very bad fourth wave, and unlike Canada, they vaccinated much earlier than us, so there was more time for waning immunity to happen. And they also spaced their doses at exactly 3 weeks for everyone who wanted it, as opposed to Canada, which we spaced it out several weeks, and we knew that, and we know even better now, that conferred better immunity. So, I don't see it as going against tikkun olam, but I think overall, as an entire world, we could do a lot more towards global vaccine equity. I'm hesitant to bring this up, but just because Marissa's in India, I think something Canada didn't do well was taking vaccines from COVAX from India right before they had their horrific Delta outbreak, and we didn't end up using all the AstraZeneca vaccines that we took from them. I think that was we were trying to protect our population, but I think that was sort of a blemish on our pandemic response.
I don't see any other questions in the Q&A, so I'll allow myself one more. And this time it's for you, Nathan, on a completely different subject. So during this pandemic, many churches and synagogues in particular have gone to virtual services. And I wondered whether this accessibility to people in personal care homes that you've been working with, has this helped them feel more connected to their community in any way? And do you think that, going forward, that this type of hybrid worship will be helpful to people in these facilities?
We have to remember that people who live in personal care homes, about 70% have dementia and 90% have cognitive impairment. And many of them also have sensory impairment on top of that, whether it's visual or hearing. And additionally, there's often a requirement for some staff in the care home to set up the technology for the resident, and staffing is a shortage. So I would say overall, the hope that one could replace family and caregivers from coming in with technology did not by any means replace that for older adults in particular. I do think overall, like we shouldn't underestimate the technological capabilities of older adults who don't live in care homes. And some of them who live in care homes are able to use that technology. But so I do think there is an opportunity, like there is for many things in the wake of this pandemic, to better leverage technology to help bring people together. But we need to do two things. We need to make technology more age-friendly, and we also have to have accommodations for those who have cognitive and sensory impairment, because for some people, it's simply not a replacement at all.
Thank you. That's very, very interesting. Well, I want to thank both of you and for your wonderful presentations tonight, and to you, Ted, for your skillful moderation of the event. And I just want to remind everyone that given this event was recorded, it will go up on our YouTube channel probably tomorrow. And if you want to tell friends about it who may have missed it, please do. And just a short word about our upcoming programs. For the very first time, Winnipeg will be doing Holocaust Education Week, something that is world renowned out of Toronto in particular. And now many other communities in Canada are doing it as well. And we're thrilled to say that we have several very high quality programs for a variety of ages coming up, beginning on November 3rd and ending on November 10th. If you want more details, information, please go to our website, the one that Mark mentioned, jhcwc.org. All the programs are virtual and registration is free. And thank you again. Thank you to everyone who came tonight to watch. And thank you again to our wonderful presenters. Good night.
Thank you, everyone.
Thank you. Good night.
Take care.